Hi, welcome. And do I need the mic? The back end? Yeah, Singapore, Thailand, you can hear me? Yeah. I keep my one hand.
If you be, I can hold mic for you.
No, that'll be too much. But you can do me a favor, there's so many talks today. Judy's been so kind and so generous.
9 talks.
When I fall off, you can start taking over.
Okay, yeah.
So the first introductory talk is just about past, present, and future, and this is just an introduction, but the real meat of the pudding will be in the following lectures as such. So most of you are not aware, but in the past, the way we trained previously was very crude. The MRIs were very basic. They were 1 Tesla, 0.5 Tesla MRI. The resolution was poor, and in our training days, we would probably do an arthroscopic bankard and a mini open rotator cuff repair and lots of acromioplasties. And that should be very repetitive, very boring, very pedantic kind of list, and that's it. And I think the progression of arthroscopy skills goes hand in hand with MRI development. If we never had the MRI, going to 3 Tesla and seeing deeper details and seeing about bicep lesion and seeing about subscap, we would never have come to this level, number one. It required Burkhardt and Dodibier to move the CT scan 2D to a 3D arm face view, and then suddenly it dawned upon us that the reason bankards are failing is because we are not doing arm face view, we are missing out glenoid bone loss. And that's why it takes two to tango. The surgeon could be the skilled surgeon, but if he doesn't evolve with technology, that's why we have to make out signal from now. These are some of my patients, early days when we used to do an open repair, and some patients did very well. In fact, most patients did well, but it was inconceivable that I would see what's a glenohumeral pathology. There was no way I could address the subscap in the same incision. And the scarring and the deltoid, a very painful process. Recovery from rotator cuff was a very prolonged affair. I remember one patient who had a cuff tear did very well after 6 months, 8 months. When she had a cuff tear on the opposite, she just refused to come because she just didn't want to go through the pain process as such. But that's not so true now. And there were other problems with the scar tenderness, scar adhesions, re-tear rates. There was no way to evaluate a re-tear because those 0.5 and 1 Tesla MRIs couldn't see a revision cuff because there should be a high signal throughout. And you guys have neatly dovetailed into the arthroscopy era, so you guys are not used to that small little view. I remember at one of the NEAS conferences where one of the senior surgeons was asked by a delegate after speaking about arthroscopic cuff repair, what do you think about mini open cuff repair? And his prompt answer was, it's like looking into a dark room for a black hat through a keyhole. That used to be the state. But now that has all changed. So I think we've reconciled and there's no debate on the fact that this is good. When we started arthroscopic cuff repair, we were using ethibond sutures, very crude anchors. We should thread them in ourselves. The only 2-3 instruments we had were bird beaks, which would actually cause a much bigger rent in the cuff. And sometimes that ethibond, even if you touch it with your bird beak, you should fray it, tear off. So instead of putting 3 anchors, we would end up putting 5 anchors. All that has changed. Now the sutures are top class, the anchors are crazy, they are biocomposites, they'll melt away. You do an MRI 3 years later, there's no anchor, there's no material there. Such. But the elephant in the room is that we don't accept this or we don't see the writing on the wall. The re-tear rates are still quite high. And by and large, cut long story short, the larger the tear, the higher the re-tear rate. And that's the last year's American Shoulder Elbow Society meeting I attended. I was shocked because all the prospective studies which they did, moment you start doing MRIs at 1 year, 2 years, they said it's just 30, 40, 50% re-tear rates. And then what's the moot point? Repairing if they are re-tearing again. So of course the re-tear rates increase as the tear size increases, but there are several variables here. So depends on single row, double row, depends on age, depends on muscle quality, depends on duration. And quite clearly, as you see here, as The size increases to more than 4 centimeters, repair rate 4 to 50%. Single row is double the repair rate of a double row. Age as go beyond 65 becoming higher. Good racing, you could hardly ever attempt to do a cuff repair for anybody more than good clear 3. Lot of emphasis on biologics, and to be honest, I don't think there's a firm answer that this biologic is better. There's a lot of stuff happening. These are all amino acids, glutamines, and magnesium coated anchors. You have the omega 3s, and then there's been collagen injection at 0, 1, 2 weeks, and then at 3 months and 12 months. But on a peer-reviewed journal where there is a double-blind randomized study, there is absolutely no evidence. There is one study which says that the collagen injection group did well. There is another study which says that non-collagen did much better on the repair rate. So the jury is still out on that. And there's a lot of work going on the rehabilitation side. So there's a lot of VR training, laser pointers, holographic lenses, and then there's stroboscopic glasses. These are to improve the patient's proprioception. And there's a lot of promise happening there, but that's really in the high-tech world. But after all that, it remains the case that smaller tears treated earlier in fit people who are younger will do exceptionally well, and they can resume back not only the activity but also the sport. But as it gets later and later, things get. This is probably the year of the patches. So in the last 5 years, there's been too much work on the patches, and there are a variety of patches. So all the augments and patches are not the same. So some are bioinductive, some are structural, and bioinductive ones will auto-dissolve after 3 to 6 months' time. And that's why the indications are different. Some of them are synthetic patches, and they're meant to introduce structure, not bioinduction as such. And each one claims to be better than the other. But again, these are too early days yet. There's not enough work done. We still don't know the correct indication. If you ask me, the ideal indication of patch would be a partial cuff tear in a young individual who is not ready to switch off a sport. And that's what I have done. So he wants to continue playing the very sport like gym or basketball or rugby, the very sport that caused the tear in its first place. So then instead of repairing a partial cuff tear, I don't repair partial cuff tears. So that is where you put a bioinductive patch, hope that everything heals up nicely, and then he can resume back to work. Because sending him back without operating not on, doing a repair for a small, tiny, incomplete tear, I think is using Canon to kill a rat. So those are problems. But there's such a huge divergence between the patches available from different companies. So you need to know what you have and what you want to do, and maybe you would use a different patch and a different indication as such. But the retear rates are quite real on the patches. So the xenografts have a highest retear rates, allografts have slightly lesser, but Niata's CFL has only 11% retear rate as such. So the ability to use patches for irreparable cuff tear, to use patches for augmenting a cuff repair, and to use patches for partial cuff tears without having to repair are 3 very distinct indications, and that is how I understand it. So there is no logic in using patches recklessly for every passing patient, because that is not going to move the needle. You need to know what indication you are using for your patient in these. So at the end of the day, age, fatty atrophy, size of the tear, age of the patient, double row, and early. So are probably the things that will help recover the patient better. On the future front, there's a lot of work being done on genes, and they've found out that some of them are familial and within the same family. There are those 2 genes which are the halotype 1 and halotype 2. Benson studied a lot of TNI, P3, which is a pro-apoptotic member that prevents apoptosis, and that's why probably theoretically helps the rotator cuff survive, heal, and go through. So they are trying to use all that. You must now remember that the Nobel Prize in biology in 2016 was given to a Japanese researcher who did a lot of work on autophagy. Now, apoptosis and autophagy are slightly different, you need to understand, but they are within the same realm, the same way to address them. And Their pathways may be different, but the end results are the same. So perhaps there's a lot of magic waiting here to be happen, and we'll see that in the next 1 year or so. So amongst all of these, I think a lot of work substantially has been done in AI planning, where you put thousands of MRIs down the AI tool and the application, and it will tell you which patients to operate and which not to operate. And there's a fair bit of accuracy there. There are a lot of my colleagues across the world are doing this, and they are very confident about that. It will also tell you which patients are likely to re-tear and which patients are likely to do well. And if you guys don't do it, the patients are going to do it themselves at some point. So that's why this is where the future lies. I don't think robotics has much to play. Biologics, there's a lot of stuff happening, but we don't have a one single magic answer to what is successful. But there are some serious 3D printed scaffolds which are integrated with magnesium, hydroxyapatite, and other bioinductive agents, and those are probably ones that are more successful, but we'll know in the next passing 5 to 10 years. I think Jonu is here, he's going to talk about how to augment curves, and so I won't steal his thunder, you get to hear more stuff on that. So in question, the retear rates are real, so we tend to follow them in short term. It's very important to follow them on the longer term and find out. Patients are asymptomatic, but the strength will change when there's a retear rate. So of course, the patient who's structurally intact will be far better in their outcome scores as compared to a patient who's retear. But the retear patient doesn't mean that he gets back the same symptoms. His movements are preserved, his pain is resolved, but the strength doesn't come back, and that's for sure. So there's a lot of work in regeneration in the future, and that is where we'll be heading through. So, I'm hoping there are no questions on that now, so that then we can swiftly move to the substance of the meeting, and we'll deal with the